topic is coronal plane distal humerus fractures. So we have heard of instability of elbow, and this is something sometimes associated with instability, but different ball game altogether. So it's often missed because AP view may look normal, but it is only the lateral view when you have a doubt, or when a CT scan is done, it is easily depicted. And the approach is, what kind of an approach we have to take is another challenge. And the reoperation rates following ORI of these injuries is almost in various meta-analysis, it is around 13.8%, and post-traumatic arthritis is 20%, and heterotopic ossification, something like this, is seen in 12% of these coronal shear fractures of distal humerus. Let us actually look into this. So classified by Bryan and Murray in 1985, wherein the simple capitulum fracture coronal shear is type 1 with a subchondral bone. Type 2, variable amount of articular cartilage, but with very minimal subchondral bone, is type 2. And type 3 is comminuted, whereas McKee et al. Has described when it is associated or extending onto the trochlea, so which is a common scenario nowadays with high energy trauma, is type 4 type, which is added by McKee in later. And the more practically helpful classification is Duberly's classification, wherein you have type 1 and type 2, which shows the integrity of the posterior cortex. If posterior cortex is intact, it becomes type 1, and if that is comminuted, that becomes type B. A and B in each 1, 2, 3 types. One is only simple coronal shear fracture, and 2 is extending onto the trochlea from the capitulum, and when it is comminuted, then that becomes 3. But if posterior cortex intact, it is A, and posterior cortex is broken, that becomes B. So this is helpful. How is this helpful in treating our patients? So this is a typical caucus approach, wherein the coronal capitulum fracture is being fixed with anteroposterior screws. It can as well be fixed from posterior to anterior when you have that particular bone intact. If that is comminuted, so you cannot put either anteroposterior or posterior or anterior. So that's when you have to choose. This is, you can see here, type 1, where you can bring it back into position and put posterior anterior screws, something like that. But when it is comminuted, you have to use a plate which has got angular stability. So that is a locking plate which holds it in place when it is comminuted. So all type B fractures require a plate on the posterior side. So what are all the approaches? We have seen various approaches, Cockers, Kaplan's. So you know the intervals, Cockers interval, Kaplan's, and even Boyd's, where Ancones itself is reflected from the ulna. And see what is when it is type B, wherever there is a posterior cortex involvement, it is, you get a greater access of the joint from posterior approach, and that's been said by Duberly et al. So, and another important, when it is simple and capitulum and type 1, type 2 and 3 of classification where it is type A. So that means wherever there is cortex that is intact, that's where you can actually use an anterolateral approach or a Kaplan's approach. You can extend it and then put anterior to posterior screws, and the reduction is also easy and the cortex is intact. You need not go posteriorly at all. However, lateral approach may compromise visualization of anterior joint surface and limiting surgeon's ability to assess and address medial extension into the trachea if it is comminuted over that area, and when it is involving intra-articular portion. I will show few of these examples. The posterior olecranon osteotomy approach is used in whenever there is a capitellar and trochlear fractures with posterior wall combination of a lateral or medial condyle. This is when olecranon osteotomy approach is better. And let me take you through few examples. Here is a young patient, young man with a coronal shear fracture. You can see the 3D CT and your posterior cortex seems to be intact. And in these situations, if it can either be approached from lateral approach alone, or we can approach from posterior side. It was long back, I had to approach this posteriorly through olecranon osteotomy. You can see the distal, I don't know whether the pointer is working there. Yeah, that is the coronal shear component, and that's been fixed with olecranon osteotomy approach, and that is after the restoration of the articular integrity, and the function is good. Here is a 19-year-old male who met with a road traffic accident. Here it is completely deranged joint, and you have got a coronal component as well in this. So how many of you think you have got lost MCL and LCL both in this case? Ulnar collateral and radial collateral ligaments. So in this case, that is the intraoperative picture. So where you should have access both to address medial side and lateral side also. So here towards lateral side, you can see the coronal component of the injury. So where I have used anteroposterior screw along with posterior plate, because the lateral condyle was comminuted and I had to use a plate, and medially you can see the opening. So always after you fix it, you check for the laxity on the medial side. You can see how significantly it's opening on the medial side, and that's when I had to reconstruct ulnar collateral ligament as well. And associated collateral ligaments are to be kept in mind in these cases. That's the outcome. That's the post-op X-ray, and that is after 2 years, same young man, 19-year-old. So here is another similar kind of an injury where extension into the trochlea, type 2 Duberlis with posterior comminution as well in this. So what kind of an approach to take? So whenever there is posterior comminution, it's always better to go with olecranon osteotomy kind of an approach. You can see the comminution, and that is these are the pictures. And so the same thing is addressed with posterior approach, and so you can see the articular reduction here. That's the capitellum fracture along with the trochlea piece, which is actually came into the hand, and that is before it was reconstructed. And that's again medial side was also gone in this case. So both were reconstructed. Ulnar collateral ligament repair was also done, and that is the outcome after 5 years. So sorry. That video is not working, right? So, 52-year-old, you can see coronal if you see AP view, you may not be, convinced that there is something happening, but lateral view you can see the coronal component of the injury, and all these cases require a CT scan for the reason that whether the posterior cortex is intact, that is one thing, and trochlear extension, is it going into the posterior side. So, is it just purely a anterior part of an injury? If you see this particular CT, you can see the fracture is extending into the intercondylar area on the posterior side. That is the 3D CT. This is from the posterior aspect. So, in these cases, anterior approach alone does not address the problem. So, you have to approach posteriorly, and you can make a extend the incision and approach if it is possible laterally. So, I will just show you how this is exactly what was the type 4, but extending into the intercondylar area. So, that is intraoperative, sorry, that is the intraoperative picture. So, once it is reduced and I have secured lateral collateral ligament, and so with the same incision gone on to the lateral side and reduced the coronal part and held it with a clamp here, and that is how it is fixed. That is the outcome. So, it can be associated with proximal ulna or olecranon comminuted shattered fractures like this. So, even in these cases, one should be able to identify the coronal component. So, if you see closely observe this particular CT scan, the trochlear fragment has actually fallen down, which is seen in between somewhere there, and that need to be addressed. I will show you the intraoperative picture. Interestingly, so that is the fragment which is when I opened it from the posterior side, it has actually the coronal component has fallen back. So, that has to be reduced and kept it in place. In fact, when it is here olecranon osteotomy was not required because it was already fractured and it was a transolecranon kind of a dislocation and a coronal shear injury. So, after fixation and outcome after an year. The take home is should have a eye of suspicion in case of distal humerus fractures whenever you suspect, if you suspect you can see it, and open reduction and rigid fixation to mobilize the elbow at the earliest, and most can be managed with posterior approach, but if it is not comminuted and the posterior cortex is intact, so anterior lateral approach would do the job, and associated collateral ligament injuries to be kept in mind. Check for the elbow stability once you fix coronal component also, and type 1 easy to address is type 1 is lateral approach, and type 2 onwards posterior approach with olecranon osteotomy will give good results. Thank you.